Almost every day that I'm in clinic, I have at least one patient who tells me how frustrated she is with all the work she's putting in to try to maintain, not just lose weight, but maintain her weight. And especially around the middle section. And it's all since perimenopause or sometimes worsened in menopause. But regardless, it has snuck up on her and she's frustrated. And she almost always asks me what I think about GLP-1s. I really have a hard time answering this. This is not something I was trained in. This was not something I have expertise in. And so I tend to refer to people who are experts in it, like my guest today, Ann Konkoly. So Ann Konkoly is a board certified nurse practitioner and certified nurse midwife, specializing in midlife women's health, menopause care, and metabolic health. She's the founder and CEO of Cultivate Women's Health, a private practice in Beechwood, Ohio, that offers evidence-based hormone replacement therapy and medical weight management. Ann is a Menopause Society certified practitioner and is passionate about providing thoughtful, personalized care grounded in shared decision-making and the latest clinical evidence. And as a side note, I've known Ann Konkoly for many years. We go way back. Way back to labor and
way back. Yeah.
Yeah. So, Ann, thank you so much for being here today and welcome to my little platform.
No, I love it. Thank you for having me. I'm happy to be here. I think these are wonderful topics, and this is why our private practice exists. And when I say our, I say the NPs that work with me. And, this is like the bread and butter of a lot of what we do. And it is so frustrating. And man, I'm in perimenopause and it's just frustrating. And so I get it. And so happy to talk about all the things.
Yeah. So give us the good, the bad, the ugly. What do women need to consider before starting on this journey? What should they be thinking about? The pros and cons? What are you seeing in your clinic?
It's kind of an interesting conversation because I think even so in how we frame it, because, for many of us, we've always used weight as a measure, whether it's personally or even clinically as healthcare providers. And, we've used weight as a measure and it's a terrible, shitty measurement, because it really doesn't give you much understanding of what's going on within those pounds. And so we talk about it as a weight loss drug. And the reality is these meds, the GLP-1s and receptor agonists, including, and I'll just kind of use it as the umbrella term, which are going to include your brand names of Ozempic and Wegovy, and then also of Zepbound and Mounjaro, and then all the compounded of semaglutide and tirzepatide. And it's so interesting because these are meds that, yes, people do lose weight with them, but they're really, really impressive in terms of improving metabolic health, decreasing visceral fat, improving function of how well the pancreas is working, improving, experience around food. So changing some of the neural pathways with dopamine hits. They're fascinating. Even some of the secondary uses of these meds. So you're seeing it with decreasing major adverse cardiac event, for the second, the FDA approval to use these medications to decrease the risk of a second MACE. And then for the kidney improvements and, and then there's a lot of emerging research on neuroinflammation and dementia. And so the ugly is we talk about weight and then the good of it is well, we actually are looking at a med that and an intervention that is really, really impressive in terms of its effects in an inflammatory response and on the brain and the heart. So I think that's kind of one thing to just consider about these, that they are impressive. And then I think too,
weight loss. I love the way that you put that. We call them weight loss meds, but it's not just about weight loss.
It's not just about weight loss. And I almost wish we would just start changing the narrative around that. And I think we will get there. The next 5 to 10 years with these meds are going to be fascinating to watch. It already has been fascinating to just be a part of it, but we're going to have more nuanced conversations, I think, around, retiring weight, I would hope is the measurement that we use and moving over to something that includes body composition and starts to understand, some of the shifts that many of us in perimenopause go through, which is just exactly as you said. Women come into our office and they say, by and large, the same thing, which is I'm doing the same thing I was doing. It doesn't work anymore. I don't understand what's going on. I go into a caloric deficit or I cut calories and it's not working. I'm on an 800 or 1100 or 1200 calorie diet, which is absolutely not sustainable for anyone. And it's not working. And then they say, and also, it's all in my belly. What is this? And then they go like this and they grab their belly and they say, and it's all right here. You could film it a million times. It's the exact same conversation. And that's because, some of these changes that we see in perimenopause with this decrease in estradiol, we see this decrease in our anabolic effect. These things make it more challenging for us to maintain weight, increase inflammation. And so I love these meds. I think they're super cool and interesting. I've seen, the patients in our practice have lost hundreds and hundreds of pounds. We may be into 1,500, 2,000 pounds, tons and tons. Again, weight, but drop in visceral fat as measured by body composition devices. And so it's been really, really impressive.
The visceral fat is really dangerous, right? Like visceral fat, the higher percentages that we have, the more cardiovascular health problems we have, the more diabetes we have. Like these are things that over time sneak up on us and that we don't feel like when we grab our middle, but at the middle part is reflective of there being visceral fat, right?
Yeah. It is a more metabolically dangerous type of fat. So it increases your rate for chronic disease. And it's interesting because like I even have women who come in and they're like, you would look at them and subjectively be like, oh, like she's not fat or she's not heavy or whatever word you want to use. And then we do a body composition, a tool that measures by impedance. And we're looking and like, oh, well, actually your body fat percentage is 40%, your visceral fat's 16. And like you are in a decently, like a pretty close to normal BMI, so to speak, meaning per your weight and height ratio, you wouldn't necessarily be flagged. And your body composition is not good in terms of the things that you have now in terms of your visceral fat and the increase in chronic disease that we see. I mean, we're just looking at the next 5 to 10 years of this very slow, predictable trend, which is all of a sudden your fasting blood sugar is up, then your fasting insulin is up, then all of a sudden you're watching prediabetes, and then you're watching a creeping up hemoglobin A1C into the diabetic range. And then, I mean, it's just like a vicious cycle. So
it's true. And, even speaking about cardiovascular health, one of the issues that I have with, trying to help women with menopause and hormone therapy is we know that there are risks of starting hormone therapy if your cardiovascular health is worse off. And sometimes I get to the point where I'm like, but I also know that I could help your cardiovascular health if I could get you the hormones. And so I think it'd be really interesting. Could we reduce people's cardiovascular health risks using medications, using other lifestyle interventions, but get them to the point where it's then at the optimized, safe time to start hormone therapy for them. And then they are like preventing those health issues, the sequela of cardiovascular health risks, for the next rest of their life.
Yeah. And I think the sooner that you intervene on that pathway, the better. And you're right. I mean, that's a very similar, I think, conversation, what we're having in terms of HRT and what we're having with these GLP-1s.
Yeah. That is interesting. I mean, I will tell you, I'll be vulnerable here. My vanity is like complicated because I have thought about starting.
Isn't Rachel?
Well, here, stay with me. So like I've thought about starting the medication. So I went from like having my third child being postpartum to like basically going into perimenopause. And it's right. It's like this midsection. I just want my pants to fit. And then I realized maybe that's where mom jeans came from because all of us.
It's a good point.
Right? That's where mom jeans came from. Anyway, I just want my pants to fit. And so I have thought, could I be on something short term just to get rid of my belly fat? But then I don't want the changes that I see in some women's faces or men's too to happen because I'm too vain for that. So then I'm like, how do you address that? Because we do see it, right? People call it Ozempic face and they're losing the fat in their face, right?
Mm-hmm. Yeah. I mean, it is interesting. So 2 things I would point you to just for resources so that you know of them. Dr. Rocio Salas Whalen just wrote Weightless, which came out the first year. It's really good. I read that. And then Dr. Alexandra Soa, they're both obesity medicine certified. And her book, I can't remember the name of her book, but her book is really good too. And it's maybe a couple of years old. And they're both really impressive. They are really designed for clinicians, mostly for patients, but a lot of really good information in there for us as clinicians. And one of the things that Dr. Salas Whalen talks about is this idea of, which I think coming back around as a clinician and now looking at, patients, I see it. And she said, it's interesting because there are some people where they'll go through these like times where they'll gain, right? Like maybe it's you have your third baby or you move abroad. I had a patient who just came in. She moved abroad and was in somewhere in Europe for about, 2 years. And she's like, I just gained weight and like, it was so stressful and like a relationship ended and it was a new job and blah, blah, blah. And so she's like, I really want to get back on track. So we started her on a GLP-1 and it's really helped her. And I'll be very curious, but in my mind, especially I think based on what Dr. Salas Whalen says, probably these are the people where if you put them on med because they've had this precipitous gain, like for some sort of a reason, right, an associated event, that those are people where if you help them to lose it, to use a GLP-1 to lose, they're probably in that third where they're going to be able to just maintain with good resistance training and good protein first, dietary habits. And then they're probably the people where you could start it, use it, lose it, and then wean off and maybe not need to go back on.
I mean, that's one of my questions, right? Like, do you have to stay on it forever?
Yeah. And it's about, I'd say anecdotally, it's a third, a third, a third. But it is also interesting too, because, and I say anecdotally because we have a lot of good research in diabetics and we have a lot of good research in people with BMI over 30 and now BMI over 27 with a comorbidity. But we don't have really very little data. There's one poster that was presented last year by Andrade. And I think I have it in my references and I'll send it to you, but it was this interesting, now it's observational data, so it's not RCT. But it's something, right? And we don't have a lot of data on the perimenopausal women or the women, I would say, who aren't BMI over 27 or over 30. They're in that under 27 category, maybe. So we're starting to see a little bit of data come out. And so in her research, it was looking more specifically at postmenopausal women, but postmenopausal women, giving them HRT and then giving them tirzepatide in 3 arms. Tirzepatide only, HRT only, and then a combined group of HRT plus tirzepatide. And patients, surprisingly, in the tirzepatide plus HRT arm had something I think it was either 18% or 30% additional weight loss than using one intervention alone, which is pretty impressive. But it's hard. We don't have that data. So therefore, it's hard to make predictions.
Exactly.
And I think most of us who are working in this space, who are doing, this would be considered off-label prescribing if you're doing it for the purpose of helping somebody to lose this weight where they don't meet the FDA approved criteria to use it. A lot of it's anecdotal because in case studies and maybe an expert report here and there, but most of the stuff is just much more anecdotal at this point. So kind of hard to say.
It just seems like if you could help someone before it gets bad.
Yeah.
Right? Then, like you said, if then you wean off of it, then that'd be great. And I honestly never knew that was even possible because I hear people talk about having to kind of stay on it forever. And then if people come off, that the weight gain comes back.
Well,
so that's really helpful to know.
It is. And I would just put a little caveat there and just say obesity is a chronic disease. And so the majority of people who are going to use these meds are probably people where we have some genetic component that's contributing and driving their weight and their insulin resistance. So for those people where, and these are the people who they come to the office and we do a pretty thorough intake on, tell me the things that you've done to maintain your weight in the past and what's worked and what's not worked. And tell us why, why you think in your best estimation. I mean, look, if there's one thing that I feel our patients and me, myself as a woman that I know it's what's the shit that's worked, what's not worked? And then, what do you want to kind of do from there, right? These are the people who they're just man, I have to do Whole30 once a year, or I have to do a keto, or I'm just so sensitive to carbs. I look at a carb and I gain weight. If we hear that sentence once, I hear it a million times. And these are the women where you're just it's just not normal to have to be so disciplined around food and to be so carb conscious. Carbs are a normal part, for all bodies. But some of us are super sensitive, which is probably driven by either some underlying insulin resistance or some sort of genetic contributing factor. And so that's the other piece of it is there's going to be a third, probably. It's a third, a third, a third, right? A third are going to be able, you'll treat them, lose the weight, they'll come off, and maybe they'll be able to maintain. A third, maybe it's wishy-washy. They take the weight off, but maybe they have a slow-ish regain over time.
Gotcha. Okay.
And then there's people who they come off of it, their insulin resistance drives back up, and then they are, they're approaching the same place that they were when they started the med. And sometimes you don't know, but that doesn't mean we don't necessarily try it and see.
Right. That's so interesting. And how do you help people when you find out from your conversation that they aren't really that aware of the proper nutrition during this time or even the exercise during this time? How do you incorporate that with starting medication?
It's interesting because in my mind, we have these big pillars, right? You have hormone replacement, and then you have, is your thyroid right? Do you have antibodies? Do you have a well-functioning thyroid? And then there's this, do you practice this muscle-centric medicine kind of thing that Dr. Gabrielle Lyon has coined? And this idea of, I want to build up my muscle to work as a second pancreas, essentially, right? To be a glucose disposal agent and to help me maintain blood sugars, more steady blood sugars, and also protect my bones and also, give me great looking arms. But part of it is muscle. And then a part of it is diet. So many people say, it's so true. You can't outrun a bad diet. You can't. And the foundational principles of a protein heavy and a protein first diet really do make a difference. It's one of the things we talk about so much. And then there's this genetic component, right? And so there's these different buckets, I would call them. What I tell patients is look, if you want to try a GLP-1 and we're going to do off-label prescribing, and this is shared decision making, and for your body and your kind of body composition or, your goals and desires, this makes sense, great. And I always say I would give it 12 weeks and let's just see. It's a very similar conversation of HRT. Give it 12 weeks, give it 4 weeks, and let's just observe and see what happens. What went well, what didn't work, what do we need to tinker with after that? And then from there, once people get started on it, they start to have these small wins. And it's like in Atomic Habits, when James Clear talks about this 1% improvement, it's like, all of a sudden you're like, oh, I don't have to watch my carbs so closely, or I'm not hungry all the time. And that 1% leads to okay, maybe I would be interested in a couple more greens and prioritizing my food and putting my protein first and then my veg and then my, starches. And then all of a sudden they're like, oh, maybe I could do one salad, one extra serving of greens per day. And you just keep stacking on these habits. And a part of that is getting into the gym and doing resistance training. Part of it's the protein conversation, but we just don't do it all at once, right? And so it's in my mind, in the back of it, right? It's like, we're going to watch your visceral fat drop and we're going to start to see these slow, small changes. And we're going to get to it all eventually, but we just don't do it all at the beginning. But it does take, I think, some of the best programs that are out there. And I would consider ours a really good, well-rounded program. We're just talking about oh, okay, so you want a couple more ways to get more protein? Let's get you a consult with one of our registered dietitians, and sit down and talk through what does my grocery list need to be? What does meal prep look like? So there's many pieces to it. Again, we just try not to overwhelm people because it's a huge step to even come in the office and have the conversation again, because I think so many people are just they just feel so frustrated because for years they've just been told you just need to eat less and move more. Get over it.
Right.
Really, you really must be housing the Rice Krispie treats because
No, you're so right. And, the other thing I really wanted to ask you today is about how you help your patients maintain their lean muscle, because that is the thing that I hear about GLP-1s is that, okay, you're going to lose weight, but you're also going to lose your muscle. And especially for women who are perimenopausal and menopausal, we're working so hard to help them maintain and build lean muscle that I always worry about the counteraction, of the medication. How do you approach that?
Yeah, I think it's a very good question. And interestingly, the conversation around GLP-1s has been so much around muscle, which is fascinating. And the muscle that we're losing, especially when you're in a program like ours, where we're talking about getting in your protein and this protein first strategy, we're probably doing a better maintenance of muscle than we've ever done before. So if you are a human who says oh, I once did cabbage soup diet, or I did popcorn diet, or I did all this other shit that many of us have tried over the years.
I remember hearing about people doing cabbage soup. I won't name any names on the call, but yes, I remember that.
Absolutely. How about just the plain old soup diet? Who out there has done that?
Just bone broth, right?
Yes. And to think when we're going through that kind of a restrictive diet, we're probably watching our weight drop because our muscle mass is dropping because we're not getting adequate protein in. The data is pretty clear. When you lose weight, whether it's with a GLP-1 or with a caloric restriction diet or intermittent fasting, whatever it is, you're going to see a proportionate probably loss of muscle. And I actually think we're doing better now than we've ever done about being very clear about why we need protein, and especially why we need protein as we age. It's harder for us to use the protein that we actually are getting into our diets, just as normal changes that happen physiologically as we age. And so I don't buy it a ton, we never talk to anybody about oh yeah, eat less and move more. And we never worried about their muscle mass at that point.
Really
but
true.
All of a sudden we're starting to look, but it is an appreciable. So I was talking about this with a patient last week about how she's 35 pounds down. And I'm like, look, to think that you wouldn't lose even a small amount of muscle when you're having a size reduction is actually maybe not realistic. So we might see a small one. Our goal is to make sure that we don't have this huge dip, number one, or that when we start to, with regular body composition analysis, that when we start to see your muscle mass starting to decline slowly and the trend really is downward, that then we're wait a minute, let's do a 24-hour dietary recall. Let's get in for a consult with a registered dietitian. How much protein are you
that's just it. You're tracking it.
Yes.
Right?
Yes.
And I think that I don't know of a lot of people who are doing that, or maybe that's what they maybe that's what I'm just not aware of. I'm aware of like the online
Mhm.
platforms that exist. I don't think they're doing any kind of tracking like
No.
that.
Yeah, and I think it's always so good, and I love these tracking devices too. Like the gold standard, if you were going to have one, would be to do a DEXA scan that's looking at visceral fat. They're really good. They're just a little bit more expensive. So like we have a device in our office where you come in and you stand on it. And so it's probably not perfect, but it gives you consistent measurement and some changes, and the technology is decent on it, right? And so what I love is when people come in and they're like I just had a patient, it was probably maybe a week or two ago, and she was like, I'm up 2 pounds. And I was like, well, let's like, number one, who cares? Because like, what does weight really mean? So like, let's do a body scan. So she gets on, we do a body scan. And you see this, there's this interesting, like when you look at some of the results, you'll watch and see when people start to see a decrease in fat and an increase in muscle. It's exciting. And so sure enough, she was up like 2.5 pounds of muscle from the holidays, and she was down about 2% of body fat. And I was like, this is incredible. It's like
Yeah.
you're
Oh,
metabolically
the
so much.
holidays?
Yeah. She goes, I don't know how this happened. Like I totally had some cookies over the holiday season. And I was like, okay, like who didn't have, I had my fair share too. But she was just mind blown around. Here I was thinking, I've done wrong. I didn't do it right. It's not working. I'm never going to get to where I want to be. And then she got on and I was like, you're metabolically better off than you were, which is really, really good for your lifetime cardiovascular health and your chronic disease, health. And that's the part where I get really excited. Like I know it's a weight game and stuff, and like we're looking at visceral fat and all that, but I get really excited even when, if people just have this win where they come and they stand on the scale and then they realize like, oh, weight's just an objective number. It doesn't have to mean anything about me, number one. And number two, like it doesn't give me any sense of what my body is capable of or like how well it's doing internally, right? So that's kind of one of the fun parts about this work.
Okay, so I do have a lot of patients who ask me if I could prescribe for them or if I can try prescribing because they couldn't get it covered or they're trying to figure out how to make it affordable and trying to kind of get through that process, whether they are considering spending the money for it. Do you have any suggestions or advice about that?
Yeah. So one of the easy ones is Mary Claire Haver has actually a good post where she talks about these, like, I think 5 lab tests that she wants every patient to, ask his or their provider for. There's 2 that I would focus on mostly. Number one, I mean, the lipid panel is always good. You're going to get your triglycerides and see, kind of what's going on in terms of your disposal of sugar, number one. But number 2, what I think is really useful is ask for you can either do a comprehensive metabolic panel or a basic metabolic panel. And you're going to get in there a fasting glucose. And you have to do these labs fasting and then to do a fasting insulin level. And ideally you're fasting for 8 hours. Maybe you can do 12 hours, whatever you can do. But a fasting insulin and a fasting glucose, once you have those, you can go online and just go into Google and type in HOMA, HOMA, space IR. And it's a calculator that's online that we use in our clinical practice. And it just requires that you have this fasting glucose level and a fasting insulin. And then it will spit out a number and tell you if you are insulin resistant. And that's a really useful, super quick, easy thing to do. Now, if your provider will not order these labs, which sometimes they don't want to do it because they're too busy or whatever, or they just don't know how to interpret them. And then they're like, oh, what do I do? Right. So whatever, we don't fault them for that. But the next step to do would be to go to like a Quest or a direct to consumer lab platform like Rupa or Quest, where you can just purchase the labs. They'd probably run you, I don't know, maybe $50 or something. And, if we're ordering through the clinic for cash pay patients, they're much more affordable, but get those 2 and just see, because it'll pull up if your insulin is over 10, like probably going to be insulin resistant. And when you are insulin resistant, it makes it very, very challenging to maintain and or lose weight. Like it's near impossible. And so that can be a reason where you can be like, oh, number one, for your own self-satisfaction, like, this is why it's so hard for me. And number 2, then sometimes we'll use that, whether it's a part of our diagnosis of metabolic syndrome, or we can use that in our ICD-10 coding or our insurance coding, maybe get it approved,
Right, for insulin resistance. That is so helpful. I learned something new today too. Honestly, I'm very research minded and I think, oh my gosh, we should be looking at this for research reasons too, right? If we're trying to help people, we talked about earlier, about trying to help people get to the point where they are at their healthiest to start hormone therapy so that they can continue this like trajectory of being as healthy as possible. I mean, that's a perfect way to kind of help determine their level of insulin sensitivity.
And I think too, this is where it really helps have somebody who's nuanced in midlife care for women. And so like what we do in our practice is I would say it's much more of a more focused conversation around like good midlife health and starting to think about, we want to make sure that the heart disease that is the number one killer of adult men and women, that we're doing things today to avoid that risk down the road. And the hip fractures and the fragility fractures. And like, those are the things we want to avoid, right? And the Alzheimer's dementia. And so the provider that I would encourage you to seek out in your communities is the one who says, oh, well, let's just look and let's go have you do a coronary artery calcium CT and let's have you do a lipoprotein little a. Let's make sure your triglycerides are in good range. Let's make sure you've got a CRP on file. Like somebody who's looking at it more from a standpoint of, we're not just trying to make sure you don't have diabetes. We're actually trying to think through what are the things we need to address today that are going to help you get into your, as Peter Attia calls it, terminal decade. And not only to get there, but to have a good last decade of life, right? Like where you're able to move and you're not wheelchair bound or, osteoporotic and, worried to go out in weather like this where it's snoring in Northeast Ohio, afraid that you'll break your hip and then, it's downhill from there. So that's where I think we have a really good opportunity to be more better in women's midlife health. And those are a big piece of it. But if you can't get all that, just at least ask for a fasting glucose, fasting insulin, and start there. And then from there, you'll find out a little bit more. And I think that's always kind of like more pieces to the puzzle and all useful. So
exactly. I love it. Well, I think this is so interesting, and being proactive is where it really is for women in their midlives, because it's like carpe diem. You got to seize the day today because tomorrow you might not be able to get up out of your chair. Okay. It's not so grim, but these are the decades, like these decades, 40s and 50s. If you're in it now and you're not like on top of your health, it's only going to get harder in our 60s. Yeah. And if you're already in your 60s and your 70s and you're listening, I'm not trying to tell you that it's too late or there's no hope. There definitely is, but it just might be harder.
Yeah,
right?
We're not getting any younger. And the other piece of this is like, no one's responsible for your health. And like, even if you have the luxury of children around you now, like what kind of life do you want to experience, in your last decade, in your 70s, in your 80s, in your 90s? And that's actually a really good question to ask yourself, because when you start to look at around and you're like, man, some of these old gals are like, man, they're frail. And you see somebody walking out and somebody falls, and it just happens way too commonly. And that's where I think we have a lot of opportunity now to really make a good, decent shot at, having a really good continued health through our midlife and beyond, and preparing for that last decade and making sure that we're, able to enjoy it.
Exactly. I love that. Oh, I have one last question for you, if you don't mind. Wait, what's the deal with microdosing? Is it a thing? Does it work?
It does. I do microdosing. So I'm on semaglutide on a very small, it's like probably 0.1 milligram. And most people would say, oh, that's not a therapeutic dose, to which I would say like, I can't go much higher because I, feel the side effects of it. So I think it's therapeutic for me and it is useful for me. There's not consensus on what microdosing is. So it's a good thing for your listeners to know. When somebody talks about microdosing, the question is, are they talking about using the medication at less than full dose, right? Which would be above 2 milligrams, I would consider full dose on semaglutide, and then maybe 15 milligrams of tirzepatide. And so are they using it less than full dose? Number one. Number two, are they using less than the lowest commercially available dose? So for semaglutide, that's 0.25 milligrams. For tirzepatide, it's 2.5 milligrams. So are they using it less? Some people call that microdosing. Some people say, well, like I had a patient come in last week and she said she's been working with her endocrinologist and she's lost probably 85 pounds at this point. And she's like, I do 10 milligrams of tirzepatide once a month. That would be what I would consider a microdosing protocol. It's a therapeutic dose, but she's using it, once every 4 weeks. And she's like, I've been able to maintain my weight within maybe a couple of pounds over the past year. Amazing, right?
That's amazing. Yeah.
So microdosing is a little different, kind of things to different people.
Okay.
But
that's why I've been confused.
So,
partially.
But I would say our thought about it in our practice is like, we're not getting up to full dose. I mean, most of the people that come in, we're not as often using full dose. We're very rarely going up in the commercially available dosing guidelines and FDA approved dosing guidelines, just to avoid side effects and really give people a little bit more of a gentle on-ramp to it, which seems to work really well. So, but microdosing has a different connotation based on who's using it. But I do think it's a decent strategy. strategy. We've got a lot of people who are doing it, and it's hard to say because, again, we don't have any data, like any randomized control trial data. So we're a little, kind of like blind on that. However, I hope in the next couple of years we do see some RCT data on it. Although I don't know that we will, because the reality is the drug manufacturers have no reason to
give a smaller dose.
They have no reason to give a smaller dose. And they're like, whatever, like, we don't actually want you to use a smaller dose because we want you to buy the vials and, at our lowest dose. So we'll see.
Yeah. Well, this has been super educational and interesting. I made a post earlier today that I'm kind of like agnostic on the whole thing just because I'm like, I don't know. I don't know that much about it. It's not my area of expertise, but you have educated me and I really appreciate it. I think it's really great to make people healthy. So thank you so much.
You're welcome. And the only last thing I would say is, like, I think, again, it's kind of like this conversation about HRT. And we get so many patients who come in and they're like, I don't know. What do you think? Do you think I should try it? Like, should I do it? Even if they're not acutely symptomatic, right? And we have a lot of conversations about the long-term benefits of hormone replacement. And this is another one where I think it's really appropriate for all of us to do these things, that if we're drawn to something, to do a trial of it and then to see like what worked, what didn't work, and what do I want to do differently for the next 30, 60, or 90 days. And these medicines fall in that category for a lot of people because there's so much chatter and fodder and, it's like IUDs, right? Like,
yes,
it's the same conversation about IUDs. It's like, I heard X, Y, and Z from my whoever, that the baby was going to come out holding it in its hand. And, and you're like,
I love that one.
I know. You're like, but in so many years of clinical practice, like, I think I'm coming up short of 20 years of clinical. I've never seen that happen. And that's kind of the piece that I just keep in the back of my mind, which is if you are in a place where you can afford it and it's something that you think could be useful to you, you might be right. And so like a trial could give you a lot more data on whether or not it is a good thing for you. And that's, I think, good reason to use it. So
it's a great way to put it. And for so many of these decisions, like you said, it's not like you're marrying them or, even if people get married, they get divorced, right? But you're not even getting into such like a long-term commitment. You can try something and see how it works for you.
See if it works. Yep. That's exactly it. So thank you for having me.
Thank you so much for your time. I really appreciate it.